Hi there, everyone, and thank you very much for asking me to come and speak today, and thank you, Tash, in particular. So I'm one of the transplant consultants at Addenbrooke's Hospital, and so today I was tasked with giving you an overview of stem cell transplantation, so it's obviously quite a big area to cover, and hopefully I'll give you some background and perspective, explain a little bit about how we carry out a transplant from the process of stem cell collection right through to the actual transplant pathway, and to talk a little bit about the complications of transplant, although I don't want to overlap too much with Maria's presentation, which will cover aspects of GVHD, although I will be touching a bit on that. So in terms of transplantation and how long it's been something that we've been doing, really the ability to move forward to transplant started back in when we understood more about tissue typing and how we could match people based on their tissue type in order to actually move forward to a stem cell transplant and to understand the immunology of the process. So this dates back to the 1930s and 50s when we first identified the major histocompatibility complex in mice, which is basically what gives you your tissue type, and the equivalent, which was the HLA type, which was really found later on and more understood subsequently. The first sort of marrow infusion was performed back in 1956, and since then we've been successfully performing thousands of transplants worldwide, and moved not only to the standard sort of stem cell donation, but in 1988 we had our first cord blood transplant performed. And just to take you back to the very beginning, for those of you who maybe aren't as familiar, the haematopoietic stem cell that we're talking about when we talk about a stem cell transplant gives rise to the majority of cells, to all the cells in your blood. And there are different progenitor populations that arise from these. And as you can see, we move into the sort of white and red blood cells and the more differentiated components of that, and also the lymphoid cells. And this is crucially what arises and we hope to see when stem cells engraft after transplantation. So in terms of a stem cell transplant and what it is, so you can actually classify it based on whether the cells are coming from the patient themselves, we would call that an autologous stem cell transplant, or whether the cells are coming from another donor, which is an allogeneic stem cell transplant. And in an autologous transplant, the stem cells are harvested from the patient, usually when they're in remission. And in an allogeneic stem cell transplant, then it may be that stem cells are collected from a related donor, which is most commonly a fully matched, usually HLA or tissue type identical sibling. But increasingly, we're seeing that we are able to use half-matched relatives, what we call a haploidentical donor, to perform transplants. The main source of allogeneic stem cells is a matched unrelated donor. So this will be an adult volunteer that would be identified via the Anthony Nolan registry, for example. And also we use cord blood, as I've mentioned. The other way that you can classify stem cell transplantation is where those cells have been collected from. So either directly harvested from the bone marrow or collected from the peripheral blood. So we would stimulate stem cells to move from the bone marrow into the peripheral blood and collect those to be given to the patient. And as I mentioned with cord blood can be banked at the time of delivery of a baby, and there are special, if you decide to do that, if you have a baby, there are certain places where they do that, where they will bank that cord blood. Usually you can obviously pay to have that banked for your own use, but most people will be doing that hopefully altruistically. So why do we do stem cell transplant? It's a potentially curative treatment. I say potentially because in most cases it's not a guarantee of cure. And we use it really for those patients who are at the highest risk of disease relapse. The reason for that being there is significant morbidity and mortality associated with stem cell transplant, and we have to do it for the right reasons and in the right patients. And what transplant does is that obviously it's not just about giving the stem cells that are given to the patient, but we give high-dose preparative chemotherapy and sometimes radiotherapy prior to infusing the stem cells in order to try and get rid of any residual malignant cells. So it can be it's the combination of those two factors, particularly when we are doing an allogeneic stem cell transplant, but not in the context of an autologous transplant. It's the ability to give someone a new set of stem cells, but also a new immune system that is now able potentially to detect malignant cells and destroy them. And that's what we call the graft versus tumour effect. And it's really that long-term can provide that possibility of long-term cure. So in terms of how we choose what sort of stem cell or donor type, there are different reasons why we use different stem cell sources and donors in particular conditions. So just some examples of these. We did for quite a long time, and in some cases still do prefer to use a bone marrow harvest when we're transplanting for conditions such as aplastic anemia, because there might be a lower risk of graft versus host disease. And also our choice of donor might be affected by who's available. So historically, it has been harder for those people with rarer tissue types, so particularly those people maybe from mixed ethnic backgrounds, to find a donor. And that's where cord blood really came into its own. Increasingly, as we use haploidentical donors, most people will now have a donor of some form. So that's significantly improved our ability to transplant people. Also, a lot of this depends on the experience of the transplant centre, and there are many places, particularly around the world, who are particularly skilled perhaps at doing cord blood transplants, and that would be their preferred choice of donor if they were to try and consider whether to use a cord blood donor or a haploidentical donor. So there are lots of factors that come into this. And this is really just to show you what transplant activity around the world is. Now, this is really talking about allogeneic transplant in this. And this data, so the last speaker mentioned the EBMT, the European Bone Marrow Transplant Registry, and this is where we submit data to in Europe in order to really document how many transplants are happening worldwide, what types, what are the outcomes. And this is really crucial to being able to improve outcomes and see what the trends are around the world. And as you can see from this, I hope, you can see that the most obvious thing is the ongoing upwards trend in transplant activity. More than 40,000 transplants were reported in 2014, which was the highest so far. And the majority of these remain unrelated donor transplants, but what you can see on the bottom, the increase in haploidentical stem cell transplants and the slight dip in cord blood, as we see that haploidentical probably will increasingly take over in those patients who don't have an HLA matched identical, an HLA identical sibling, or those people who haven't got a suitable adult unrelated donor. And this is the UK's activity in 2016. And just to give you an idea, really, of the total numbers. So, again, about 4,000 transplants in the UK and Ireland, and this includes adults and paediatrics in 2016. And the split between autologous transplants and allogeneic transplants being about 2/3 autografts and 1/3 allograft. So, in the next section, I wanted to tell you a little bit about how we collect stem cells and how we give them back. So, the majority of transplant, when we first started transplanting, were carried out in this manner. And this is how we continue to collect some stem cell donations, which is directly bone marrow harvesting. And for this, the patient or donor would undergo a general anaesthetic and would have bone marrow collected from the pelvis. And quite large volumes of marrow need to be collected for this. And clearly, you know, if you're going to have this done, particularly if you're a donor, it means an overnight stay, coming in, quite a lot of pain, and it will put you off work for probably a couple of weeks, maybe a bit longer, if you've got bad enough back pain. Sometimes people need transfusions after they've had a bone marrow harvest. And this marrow is then collected and will be taken to a stem cell lab where it will be processed and then administered back to the patient. So as you can guess from following on from that, increasingly we like to use peripheral blood stem cells because also you get a very good cell dose when you do peripheral blood stem cell harvesting. So in this, what we do is we would mobilise the stem cells from the bone marrow into the blood. So for a healthy donor, we would use a drug called GCSF, which is essentially a type of hormone in a way, in that it's stimulating the cells in the bone marrow to be released into the blood. And these cells can then be collected by the donor going on this machine. So this lady looks very happy sitting at her machine, which is a bit like if you're donating blood. It's an apheresis machine that collects those stem cells, and those again would go off to be prepared by a stem cell lab in order to be either infused if this is going directly to a patient, or the alternative is when a patient who's having an autologous stem cell transplant needs to donate their stem cells. They would usually have a bit of chemotherapy to stimulate their bone marrow, and then the GCSF injections, and then collect these stem cells. And as it says here, usually on day 10 for patients of that sort of regimen, and on day 5 for donors. And so it takes a good few hours to collect the stem cells, enough stem cells, and sometimes people need to come back for a second day's harvest. And so those stem cells may either be given, as I've said, fresh to the patient, or usually if it's an autologous donation, you would donate those stem cells and they'd be frozen down so that you would then be admitted later on to actually go through your autologous stem cell transplant, and those cells would be thawed and given back to you. So to just sort of explain the transplant pathway for those of you that may not be as familiar. So firstly, a question of indications and particular disease types, and why we do a particular type of transplant in specific settings. So if you look at the autograph column, so this is taken from the British Society of Bone Marrow Transplant website, which has the indications guidance that we all use to tell us what is allowed in terms of when we can do a particular transplant for a particular disease indication. And so if we look at the autograph column, you can see, so S means standard of care. And you can see that essentially there are two large indications for an autologous transplant. Myeloma, you would have an autologous transplant, and it's standard of care to do this as part of first-line treatment, and it can be done subsequently at relapse. And then secondly, in lymphoma, usually beyond the first remission. Again, because this is a high-risk procedure, and you only need to do this for those people who have more aggressive disease that's returned. Then, in terms of allogeneic stem cell transplant, there's a wide variety of indications, but again, we don't do allogeneic transplants for everybody, because not everybody needs an allogeneic stem cell transplant. A good example of that is in acute myeloid leukemia, where we can stratify people according to their disease type into those people who have what we call good risk disease and could be treated and cured with chemotherapy alone, but those patients who are not in that, who don't have that good risk profile, who we would then decide are more likely to require a transplant up front. And so there's a wide variety of indications for allogeneic stem cell transplantation. So with an autologous stem cell transplant, if we focus on that for the next few slides, the purpose of this is really to allow the patient to receive a large dose, a high dose of chemotherapy. If it's less about the stem cells that you're giving back, the stem cells are being given back to that patient to allow them to recover. What you're trying to do is to be able to give them the maximum dose of chemotherapy to try and usually to eliminate any residual disease. So we use this usually when a patient has already achieved a best response to chemotherapy for whatever disease they have, but this is now trying to maintain their remission for as long as possible. And in some situations, for example, with high-grade lymphomas, an autologous transplant can definitely be curative. And as I've mentioned, without giving these stem cells that have previously been stored for the patient, once you give a very high dose of chemotherapy like this, someone would take a very long time to recover their blood counts, and in the absence of having these stem cells giving back to them. So this is what allows them to recover. It doesn't have any of the immunological conflict that we see with allogeneic transplantation, which I'll go on to explain a bit more about. And it's also used because it can be used in solid tumours. We do this particularly at Addenbrooke's because we have quite a large paediatric cohort of patients who have autologous transplant for their solid tumours. And also it can be used in autoimmune disease such as Crohn's disease and multiple sclerosis, because that chemotherapy has a very immune suppressive effect. So what are the benefits? As I say, being able to give that very large dose of chemotherapy may give sufficient anti-tumour effect to leave very few residual tumour cells. And it's actually it has a very low chance of dying from this procedure, 3%, and can be very well tolerated, and increasingly people are moving towards doing particularly these transplants and also allogeneic transplants. They'll move towards the ambulatory setting in many places because people will be able to at least start off their treatment maybe in a day unit, and the ability to do that is partly because this is actually quite in the scheme of things, quite a well-tolerated procedure. So what are the disadvantages? The stem cells that are given back could be contaminated by tumour cells, and I guess that's most likely in the case of myeloma, where it's very unlikely or less common that we would have completely got rid of all of the tumour cells prior to the stem cell donation. And that really leads to part of the reason why an autologous transplant is not curative in a setting of myeloma, or usually not. But people can have very sustained treatment-free periods, and that's really the benefit for them. Several years in some cases of not needing any form of treatment for someone's myeloma after they've gone through maybe some rounds of chemo, an autologous stem cell transplant, and then a long treatment-free period. There isn't any graft versus tumour effect, so that is obviously a disadvantage. So in terms of the patient pathway in an autologous transplant, so you would expect to be in hospital for about a month. Main side effects are those of chemotherapy, so nausea, vomiting and mucositis, which you're, I'm sure, very familiar with, and is particularly something we see in the context of using melphalan, which is sort of a backbone of many of these regimens. And then having very low blood counts, so what we would call bone marrow failure, and therefore a higher risk of infections and a risk of bleeding. And essentially, once the patient has had their preparative chemotherapy and then been given their stem cells back, what we're waiting for is for their blood counts to recover, which is what we call engraftment, and that can occur as early as day 10, 12 onwards. And people are given the GCSF injections again to help boost that recovery and speed that up. And then when people are discharged, essentially people can be pretty, I think the thing we see most is fatigue. The ongoing side effects of having had significant mucositis can carry on, and people report some of those symptoms: difficulty eating, loss of appetite for some time after, and I'm sure you've all come across people still experiencing some of those symptoms after they've been discharged. And we would then continue to see people long term in terms of monitoring them for disease recurrence. And so this really just highlights to you what sort of happens in terms of the drop in the blood count. So people, in this instance, we're looking at neutrophils and platelet counts, and they're initially high, and then as we give chemotherapy, you'll see that by day 7, after the stem cells have been infused, most people will have reached their nadir, their lowest blood counts, and then you start to see that rise that gradually happens, and most people start to feel better as soon as their neutrophils start to recover. There's a perceptible difference in how people are. In terms of complications of a transplant, so I've mentioned a transplant-related mortality, which is essentially due to an overwhelming infection early on in the transplant process. There would be some reduction in quality of life early post-transplant, but usually people are recovering at least by the 3-month mark, and then beyond. And as I say, in some cases, you will have an improved quality of life because you'll have an extended treatment-free period. There is the possibility that early relapses after an autologous transplant could be more aggressive, and there are potentially long-term side effects such as secondary cancers, which include solid tumours and myelodysplasia, which is something that we do see following autologous transplant. So if we now talk about allogeneic stem cell transplant, as I've mentioned, the indication for this covers a range of haematological malignancies, but also non-malignant conditions, so bone marrow failures such as aplastic anemia, and also we're seeing this used in other conditions, so in some of the hemoglobinopathies such as sickle cell disease and thalassemia. But also immune deficiencies, and in fact some of the earliest transplants were done for that indication, particularly children, and then some of the metabolic disorders. And in order to be able to do an allogeneic stem cell transplant, you need to know about the tissue type. So the tissue type is based on something called the HLA, the human leukocyte antigen. We all have this molecule, and there are a number of different types of HLA molecules, and essentially it's a fingerprint for us. And these markers are expressed on many of our cells, all of our cells, and we use the tissue type, which actually, particularly for a Caucasian population, there are many that are repeatedly represented, and that's why when you do a tissue type, there's a good chance, about 30% chance of finding an unrelated donor in that situation. And to have a sibling donor, you've got a 1 in 4 chance of one of your siblings being a donor. And we know that by closely matching the HLA tissue type, we can successfully carry out a transplant. And over time, we've got better at the way that we can actually investigate the HLA to deeply sequence and understand what someone's tissue type is to improve the degree of matching. And we usually match based on 10 factors. So the 3 HLA class 1 alleles, A, B and C, and also the 2 HLA class 2 ones. And some areas use DP as well. So the primary thing we look at is the tissue type. We do take into account people's blood group, but you don't have to be a blood group match between the donor and recipient. The other thing that we prioritise for is for exposure to CMV, which you may have heard of, a virus called cytomegalovirus, which causes us a lot of problems post-transplant because it can reactivate within the patient and then, if allowed to continue, causes CMV disease, which can be life-threatening. But often what we're more focused on these days is not the issue of the disease, but more that there's a lot of toxicity that goes with trying to treat this recurrent problem. So if we can match the patient and the donor for their CMV status, then if you have a negative recipient, they've never been exposed, nor has the donor, then the chances of this being a problem are minimal. And if both the patient and the donor have seen this virus before, then the donor brings their immunity. And that means that although reactivation is likely, it would also likely come under control more quickly and be less of a long-term issue. And we know that the greater the mismatch between the patient and the donor, the greater the chance of graft rejection and of graft versus host disease, because this is the key immunological factor that's going to drive acceptance or rejection. So again, in terms of preparing somebody for their allogeneic stem cell transplant, we want people to be in their best state in terms of disease reduction, and we still need to give them chemotherapy to condition them. And this is again partly chemotherapy, which will be aiming to reduce the level of disease to the lowest amount, because that gives enough time for those stem cells to, when they mature, start to act and to fight that person's underlying malignancy, but that takes time. And also we give drugs to suppress the immune system of the patient and the donor, trying to prevent both rejection and early graft versus host disease. And we can give different strengths of preparative treatments. So we may give high intensity chemotherapy, our strongest being myeloablative chemotherapy regimens, which are generally reserved for those who are aged less than 40 because they are so strong, and the transplant-related mortality is high. We also have lower intensity conditioning chemotherapy regimens, which are what we tend to use for the majority of patients who are frequently over 40. And so again, in terms of the transplant time course, what you will see is that we give chemotherapy, we may give lymphocyte depleting antibodies. You may have heard of something called Campath or ATG, and these are there to try and prevent graft versus host disease both early and late. And then immune suppression medication need to be started just before the stem cells are given to the patient, and then you have that same fall in counts and then a rise, which we hope to see from about day 14 to 21 onwards. And again, that basically demonstrates engraftment. But during that period, people are in hospital needing lots of blood product support and also at risk of major toxicity, and the main issue being the effects of the chemotherapy they've had and also vulnerability to severe infection. So how do we decide what type of transplant to perform? As I say, age is one factor. Comorbidity is also an important factor, and the more comorbid conditions you have, the more the more risky a transplant procedure is going to be, and the less likely that we'll be thinking about something like a myeloablative transplant. Probably a myeloablative transplant will have the most major effect on disease control and the lowest risk of relapse, but it will have the highest complication rate. The reverse is obviously true of reduced intensity conditioning, where we have less chemotherapy to control the disease, but it is much lower risk. And you're very reliant then on the stem cells from the donor doing their job and fighting the leukemia. Graft versus host disease will be there whichever form of transplant you perform. And so this is just a little bit to sort of try and explain about the type of transplants and where intensity, how we define intensity. And essentially, you will talk about giving more and more radiotherapy. So at the far end, you have the highest levels of radiotherapy, giving you a true standard intensity conditioned transplant. And high doses of busulfan and cyclophosphamide are what we commonly use, particularly in AML transplants. And so in terms of myeloablation, we talk about total body irradiation, which will be given over several fractions, and also cyclophosphamide is commonly used, and as I've mentioned, busulfan. And as I've said already, we use this particularly for younger patients. And something we see frequently and that we rely on your help with is significant mucositis in these patients. And that is pretty much almost universal, I'd say, in those patients that receive one of these types of transplants. So with reduced intensity conditioning regimens, as I've mentioned, they have allowed us to do transplants in older patients and those with comorbidities. They are less strong. There may be less of a need for blood and platelet support in some patients. It's possible that the duration of neutropenia will be reduced and that there'll be less infection in this situation. And we can use this in a group of patients who are actually very heavily pre-treated. There may be reduced graft versus host disease compared to a standard intensity transplant, and it may be that we can delay the onset of graft versus host disease that we may see beyond day 100, and that's partly to do with the preparative agents that we use in the transplant. So some of the disadvantages are that perhaps the reduced in strength of the chemotherapy that we use in these reduced intensity conditioning regimens may be less active against the cancer itself. As I say, we're heavily reliant on the graft versus tumour effect, and sometimes, and actually quite frequently, we may need to boost that subsequently by giving people donations of lymphocytes, the ones that really do fight the underlying malignancy, and we can do that post-transplant. And we're guided by things called the chimerism, so tests such as the chimerism, which can give us an idea of how well the transplant is working. And we can use it as a proxy to tell us how effectively the graft versus tumour effect is acting. So it's a similar sort of patient pathway for an allograft. You're in hospital for 4 to 6 weeks in isolation. You have the same sort of problems of nausea, vomiting, and as I've mentioned, mucositis. And there's a significant risk of infection, and these can be a broad range of infectious organisms that can cause issues here. And as you've heard from that really elegant presentation about nutritional failure, this is a major issue for us, and something that we work very closely with the dietitians on our ward to try and improve. Many of the problems we have come from using multiple drugs and getting multiple toxicities as a result of that. And so we would then see our patients when they do go home, which will happen when they've been grafted, they're free of infection. We see them initially weekly at in our clinic, but also in between times in our day unit. We need to use strong immune suppression to prevent graft rejection, to control graft versus host disease. And the risk of infection still persists for these patients for a significant period of time post-transplant. And really what happens depends on what complications patients develop in the post-transplant setting, specifically graft versus host disease. And again, we need to keep a very close eye on weight and dietary intake, as many of these patients struggle once they get home. And it really is imperative to keep an eye on this. So I'll just touch briefly on mucositis. So this continues to be a significant problem. And most of our care for this is supportive. There has been some use of other agents such as palifermin, which is a keratinocyte growth factor, but really there's been very little that's sort of improved our ability to control this. So I will just briefly touch on graft versus host disease, but I won't go much further on this. So I think that you will be aware that graft versus host disease is a major complication of allogeneic stem cell transplant. It can be broadly separated into acute and chronic, and acute particularly can be lethal if it happens suddenly and in the early phase post-transplant, and chronic may be more disabling. The pathogenesis is really related to that difference. Although the tissue type is matched, there are so many differences between the recipient and the donor, and in the context of having lots of chemotherapy, insults to tissue such as the gut from chemotherapy, this activates the immune system and results in the donor recognising the patient as foreign, and causes a train of immune responses that lead to graft versus host disease. I won't go over this because I suspect much of this might be covered, but acute graft versus host disease can be graded. We use the modified Seattle-Glucksberg criteria, which you may be familiar with. And we use this because it's prognostic. The more severe, the worse the outcomes, with a significant mortality risk. There are guidelines as to how we manage acute graft versus host disease, and essentially this is based on heavy immune suppression using systemic steroids and then adding in other agents. But the real worry with graft versus host disease is that you continue to have to immune suppress patients. You continue to expose them to that risk of overwhelming infection, and it can be very tricky to manage it. Something that Shamila is going to be talking to you later on today about is extracorporeal photopheresis, or ECP, and that has recently been approved as one of the second or third line treatments for graft versus host disease in the acute setting, although it has been used in that and in chronic graft versus host disease for some time. So chronic graft versus host disease, again, essentially a similar underlying pathogenesis, but a longer-term chronic problem affects your quality of life, causes failure to thrive, and for the patients where we need your involvement with, we will need, in many of these patients, nutritional support, sometimes enteral feeding. So as I say, the majority of treatment involves using a variety of immune suppression agents. So to end, really, just to sort of say a little bit about where we're going with stem cell transplantation. So what we'd like to do is to reduce the toxicity but retain the efficacy of transplant. We'd like to improve conditioning regimens. Really, people do still relapse after transplant, and that's what we're still trying to combat and work out. How can we prevent that? What can we do as part of the transplant itself, or maybe early after the transplant, to reduce that risk? How can we reduce their risks of infection? How can we combat infections without some of the toxic drugs that we have? And also the emerging experience we're getting with haploidentical donors, which has really expanded even further our options for patients and allowed us to transplant more people. The ideal would be able to separate graft versus host disease from the graft versus tumour effect, but I think we're a long way off that at present, but it's where we're going for. So thank you very much.